It's truly an honor to be here and to participate in these discussions and be part of the faculty. These guys are just up here, just brilliant. I always learn something from them, and I just learned something from Pierce. Polyaxiality. I didn't know that was in the dictionary. Thank you for that. I'm not going to talk about high-grade spondylolisthesis, spondyloptosis, these big herendioma kinds of spondylolisthesis. I certainly trained on those types of cases, and I can tell you that my experience with it is pretty broad. But I'm going to try to narrow this down to the typical kind of case that we see every day in our office, and it's some of the issues around that and how I've sort of evolved over time to approach these kinds of cases. So L5-S1 spondylolisthesis is certainly not uncommon in our adult patients. Many of the patients are diagnosed incidentally. They show up and just have some back pain. They get an x-ray. They've got a spondylolisthesis. They never knew it. Many patients never require any treatment for it at all. So there are patients who obviously live their whole entire life with sometimes a high-grade spondylolisthesis and never require any treatment. As is daunting in most low lumbar spine cases that patients present with pain, identifying the pain generator can sometimes be a challenge. It's not always the spondylolisthesis that's causing the problem. It can be more proximal levels. It could be the degenerative disc at 4-5. It could be a herniated disc at 4-5, facet arthritis, so on, SI joint pathology. I mean, all of these things we have to have an algorithm to kind of sort this out. But why does L5-S1 spondylolisthesis become painful in adults? Well, it's not the pars defect. That's when you're a kid, you get a stress reaction, you get a defect, the acute fractures. Yeah, they're probably the source of pain. Everything else is normal in the child. We can pretty much assume that it's the pars defect. And if we intervene early enough, we can get it to heal. But in an adult, it's probably the progressive degenerative disc disease that occurs at L5-S1. The disc collapses, right? You get foraminal stenosis. There's segmental instability. Sometimes they're hypermobile in flexion extension x-rays. And clearly, there's a mechanical source of pain there. And often, the ones that we're intervening for surgically are the ones that show up with the leg pain. And typically, that's because of the L5-S1 foraminal stenosis. And we've seen many examples of that this morning. Like most surgeons, I'm old enough. I hate to say it, I'm old enough. But circa 1991 is when I completed my first fellowship. And everything was posterior. I was a posterior guy. We do a big whack for these single-level cases, right? You make a big line incision, you do a complete gill laminectomy, and then you throw it out. We didn't have a bone mill. We didn't chop it up and put it back in there, which is something I evolved to later on. It's like you waste this perfectly good bone. You go and you destroy the iliac crest to get all the bone graft you can. A patient comes back and they've got pain over their bone graft site. You solve their problem with their spondylolisthesis. And we were using semi-rigid pedicle screw instrumentation. We're putting them in braces with a thigh cuff because that's the only way you can immobilize the lumbosacral junction. And they were admitted the day before. They spent 4 to 5 days in the hospital getting the brace fitted. It was god-awful. I had to evolve some way. I was tired of dragging my knuckles around doing this kind of stuff. So, we've all evolved in our practices over time. And again, I'm old enough to have gone through many iterations of this posterior approach, typical posterior approach to spondylolisthesis. Again, you're still making a big whack. You're doing gill laminectomy. Now we've got better pedicle screws, more rigid. Not putting them in braces anymore, but still taking iliac crest bone graft because this is before osteobiologic. This is before BMP. Okay, so we're all taking a bone graft. Still, patients coming back with bone graft site pain. It's just and then. Okay, now I'm into the PLIF thing, and I'm doing bilateral allograft bullets, in the disc space, and pedicle screw instrumentation again. It's one iteration after another. And then we've got the cage rage, in the early 90s. And now we've got everybody's coming out with all sorts of different cages, PEEK, titanium, so on and so forth. Went through every single one of these types of cages, and Harms cages included, doing the Harms technique. Bilateral T-lift, every iteration you can imagine. I hate CSF. I hate doing L5-S1 fusions from the back. There's got to be a better way. Some of these are just absolutely challenging to get in there and really do a good posterior approach to these things. So For me, the game changer was when I shared a mentor with Dr. Lieberman in Nottingham, England, where basically these guys did everything themselves. They did all their own anterior approaches, and it really turned me on to the anterior approach for lumbar pathology. So for me, it was a game changer. Now, initially, doing femoral ring allograft, right? We didn't have all the fancy cages and the things we have today, but it worked. It definitely worked. So that's kind of what I grew up with, doing it initially, and then graduated into different cage iterations and so on, doing the same approach, but learned how to do my own ALIFs while in England and came back and kept doing them throughout the rest of my time. So transitioned from doing open screws in the back to percutaneous screws. But these are all still flip cases, right? Straight ALIF, flip them over, put your screws in. And so the ALIF approach has really become my workhorse. And after having an experience in England, and probably some of these cases that I was involved in were published by our mentor, Dr. Webb, in 304 consecutive cases, all done by spinal surgeons. There's no access surgeons. Okay, basically it's safe. The complications are low. Most of the issues you get into are vascular, usually venous, and most of those can be handled by the spine surgeon themselves. And I certainly learned techniques of how to handle those annoying venous bleeding issues. So I felt confident that I could do this myself. Just to reiterate some of what you've heard already, the advantages of an ALIF approach. There's less muscle disruption. When you go through an anterior approach, you don't cut any muscle at all. You just move things around. It definitely preserves, and if you do it percutaneously instead of open in the back, it preserves the posterior muscles and the ligamentous attachments. I love doing these by a frontal approach because I don't have to mess with the epidural space. There's no epidural bleeding. There's no epidural fibrosis. You don't bugger up the nerve roots. You can perform much more thorough and complete discectomy and end plate prep. And we can put in bigger cages. We can stuff more graft in. And we can, as has been discussed here in the panel, you can actually reduce a lot of these spondylolistheses very nicely if you need to from the frontal approach with a variety of different techniques. By restoring the disc height, we can restore foraminal height. We can achieve indirect neural decompression, and has been hammered on the previous discussion. We get much better lordosis through an anterior approach. So that was my epiphany, my conversion to the anterior approach for these cases. And there are now in the literature, and I try to keep this just to L5S1 spondylolisthesis, and there is some good literature that has come out that has begun to compare posterior approaches, particularly TLIF versus an ALIF with perc screws for L5S1 spondylolisthesis. And the advantages after reviewing this literature is that, and it has been highlighted again this morning, you get a greater restoration of segmental lordosis and even regional lordosis. You can restore greater disc space height. Fusions are probably equivalent. Some of the papers indicate that they had better clinical outcomes with the ALIF approach with posterior percutaneous pedicle screws versus TLIF. Again, just reinforcing the utility of the anterior approach for these cases. Indirect decompression, there was some discussion about that on the previous panel. It works. I mean, it definitely works. I tell these patients, look, we're going to do this. We're going to do this anteriorly. I know you have leg pain. I know you've got foraminal stenosis. I'm pretty confident we can get that reduced and take the compression off your nerve. We're going to do percutaneous pedicle screws. If by chance you continue to have leg pain, you may require a minimally invasive foraminotomy and direct decompression later. So I prepare them for that. I've only ever had to do it once. The patient had left leg pain to start. They woke up with right leg pain, and it's because there was a little bit of an osteophyte off the back of L5, which was like a hook, and it hooked the opposite L5 nerve root. Just took the patient back, just knocked that thing off, that pain went away. So it happens rarely. I think the literature is now reinforcing the fact that indirect decompression works. There's actually some literature, especially with central stenosis, that over time the benefit of indirect decompression is actually additive, so that serial MRI scans show that the canal actually continues to expand over time. So you get that initial decompression, and sometimes it's only a matter of millimeters that they need more room to stop their dynamic neurogenic claudication, and you'll hear probably more about that in Sig's talk about degenerative spondylolisthesis at L4-5. But for an isthmic L5-S1 spondylolisthesis, it's virtually always just the foraminal stenosis that we're talking about, and so I'm very confident that we can get indirect decompression to do this. Okay, so just some cases. This is a 50-year-old female food service worker. She's got typical back pain and leg pain, a little bit of hypertension. She's had a couple of cesarean sections. She's had an umbilical hernia repair. None of these things really scare me as far as her history of doing an anterior interbody fusion. I think you can do that safely. I've done many, many patients who have had hysterectomies and C-sections and so on. You can go through the same incision and still go medial to the rectus and get there safely. And John Williams and I have talked about this multiple times. I'm a big fan of going on the right side. I do many of these from a right-sided approach, and I learned that from doing total disc arthroplasty. You go on the right side first, you do your arthroplasty, and if you need to ever do a revision, you can go back on the left side, and or if you need to approach 4-5, now you've got a soft tissue envelope that's not been violated, and you can get there safely. So I'll do a lot of them from the right side. So here's this Isthmic spondylolisthesis, basically no disc left, foraminal stenosis. That explains her leg pain. She probably doesn't have the best soft tissue envelope. The body habit is to be doing an ALIF, but as you gain confidence in using this technique, you're gonna do it. Easily accessible. Her pubic symphysis is certainly below the L5-S1 disc space, so you can get there. That's something you have to consider when you're doing your preoperative planning. Okay, and some of these reduction techniques we just talked about in the panel discussion. This particular implant, I just anchored it with one fixation point into the sacrum. Now, Pierce was talking about doing it where you lock it into L5 and then you reduce it. You lock it. You can do it either way. This is a peak cage, so I know that L5 is going to slide back on top of that cage, right? You stuff it with all sorts of bone graft. You just lock it into S1. You can see how far back that cage is. You're looking at it and you go, wow, it's practically in the canal. So when I put my screws in, these are perk screws. I'll tighten the rod to the S1 screws first, fix that, and then with your reduction tubes, your towers on the screws, then you start to you can reduce and pull that L5 back all the way practically. So once you've done the anterior approach and you've taken out the anterior longitudinal ligament, you've done your discectomy, these things are quite mobile, and you can do a good job of reducing them if you need to. Not every case has to be reduced. And that was our final film with a good robust fusion at L5-S1. There's no posterior fusion in this case. It was all just perk screws. I rely on the anterior interbody fusion and disc prep to get that job done. It's a little bit more recent case of an 84-year-old gentleman, and to Izzy's point, every case is different. Patient selection is important. You got to pay attention to many, many different things. When you're looking at these people, you got to look at everything. You have to look at osteoporosis is a big one in older people. I've had many disasters in not paying attention to that early in my career, especially at L5-S1. I've seen every manner of failure in those cases. So I'm screening many patients who have never had a DEXA scan, using Hounsfield units to understand what degree of osteoporosis in the spine. I'm sending them off to be pre-treated for their osteoporosis prior to me ever doing any sort of spinal instrumentation. So I think it's a big, big thing that's not been really appreciated. And as a spine surgeon, you really need to. So the guy's had 2 prior L4-5 discectomies. He had leg pain. The surgeon thought that was the source of his pain. Did a discectomy at L4-5, didn't take away his leg pain, and the solution was to do yet another discectomy at L4-5. So the guy's had 2 discectomies at L4-5. His L5-mediated leg pain never went away, and he's had some previous anterior abdominal work. He's had mesh put into his belly here. So this is This is his x-ray, and you can see the degree of spondylolisthesis, disc space collapse, and of course, you know he's going to have foraminal stenosis, so you know what his MRI is going to look like. You can see the little tacks and staples from his mesh, his inguinal hernia repair. And here's his MRI scan, complete disc space collapse, basically no foramen, the L5 nerve's not happy. That's why he's having the leg pain, not from an L4-5 disc herniation. So because he's had 2 prior discectomies at 4-5 and pretty wide laminectomy there at that level, I decided to include that. So here's his MRI scan. Caveat here is make sure when you order your MRI scans that they do disc cuts. I call this the poor man's MRI. All they did was they stack images. They did not do discal cuts here. So you don't really appreciate the vascular anatomy here. I want to know what my corridor is going to be. On the left is L4-5. That's pretty amenable to ALIF or OLIF or however you want to do it. Vessels are in a good place. Got a nice window there. L5S1's on the right. Even though that cut is not aligned with the disc space, I can still appreciate that there's going to be a wide window between the vessels. We'll be able to get there, no problem. One thing you always need to pay attention to, especially with these patients with an Isthmic L5S1 spondylolisthesis and high pelvic incidence and steep sacral slope, is you've got to be able to get there. You've got to be able to see it when you get there. Get your x-ray so that you can see the front of the pelvis, the symphysis pubis. You want to make sure that you're going to be able to see. Some of the toughest cases are those where you can maybe be able to get there, but you can't get your instruments in, and the cage can be a challenge to get in there as well. I think that's almost pushing the limit. I almost decided not to do this to an ALIF, but I said, look, I think we can get there and do it. Had a general surgeon assist me just because we were so low, and that's right in where all of his hernia repair was. We ran into a bunch of mesh and scar tissue, but able to get through it, no problem. Got to the retroperitoneum, exposed everything, no problem with the vessels, and I was able to get the cages in. Put a blocking screw there to hold the cage in at the bottom, and then put the second cage in at L4-5. Flip percutaneous screws, and the guy's leg pain went away, and he's back to playing golf. So this is basically the creature I am today, how I've evolved. I'm not dragging my knuckles around anymore, struggling with posterior T-lifts, pliffs, whatever. Again, I hate CSF. I hate epidural bleeding. Not a lot of fun. You get these, even in these ones with a very high grade or high pelvic incidence and sacral slope, you're practically standing on your head trying to get a T-lift in from the back. So no matter how you do it, it can be a challenge. But I've really graduated to doing these almost all anteriorly. There are exceptions, obviously. You have to respect the patient's anatomy. You have to analyze each case individually. I still do T-lifts for this, as much as I hate them. But there are those cases where you're going to have to do them. So you got to know how to do both the front and the back equally well, and pick and choose as you need to. Use the tools out of your toolbox that work for you, but you got to know how to use them all. So I've basically transitioned to try and do more and more of these in a single position. It's definitely feasible, and I found that the robotics are very helpful in the accurate placement and planning of these cases for the posterior fixation. So the whole idea of ALIF versus OLIF. I mean, this is an ALIF in the lateral position. This is what this is. Okay. An ALIF at L5S1 is always anterior to the psoas. So calling it an OLIF or anterior to the psoas approach, I mean, versus ALIF, it's all the same thing. It's just an ALIF in the lateral position, right? And so what's the advantage of doing that? For me, it'll decrease the operative time. We're not flipping the patient anymore, so it's definitely faster. We can reduce some blood loss, and these are publications in the literature that have highlighted all the pros of doing it that way. You can decrease their length of stay. There's less chance of ileus, and I think that's true. But if you're facile at doing a regular ALIF, I think, and mobilizing patients, I think you can have a pretty low issue of abdominal ileus and so on. So it's definitely feasible, it's safe, it's effective. It's all about the preoperative planning, and that's one thing that I think all of us on the panel will hammer home to you every time, is that you gotta study your patient. You gotta understand their particular anatomy and do the correct surgery for them. When you're doing ALIF, it's all about the vessels, right? I would love every case to be like A there at the top, where you got this huge window. The vessels are way lateralized. You can drive a truck through the anterior disc space at L5S1. But be careful. Some of them, they don't always look like that. Some of them look like B there, right? So the vessels are all overlapping. I'm probably not going to do that with an ALIF. With a guy who's got a steep angle, and I'm going to be struggling to get there. So this is probably my TLIF case, right? And again, emphasizing the fact that you've got to get there, you've got to have a line of sight, you've got to be able to get your instruments in there, pay attention to where their sacral slope, their pelvic incidence, and whether or not the pubic symphysis is going to be in your way. So it's all part of the preoperative planning. Again, the advantage of doing them in the lateral position is that much of the abdominal contents, the peritoneal contents, will kind of retract themselves. So we're not having to retract as vigorously as we would with a straight anterior approach. So in the lateral position, that stuff just kind of falls out of the way, just makes it easier to mobilize the retroperitoneal space to get there, much easier on the abdominal contents. So positioning is key. You got to have the patient, their hip and knee extended, not only for exposure of the L5S1 space, but also to help facilitate lordosis. I don't find it particularly difficult to get the lordosis, no matter how you do it. I stopped using a bump under the abdomen in straight ALIFs. Here, I think it's more about really having the hip and knee out of the way, so you can access L5S1 with this lateral approach. This is just an example of where you can put your incision. This is a case where the surgeon is doing actually 2 levels, so 4-5 and 5-1. So the incision is a little bit more oblique, a little bit more posteriorly. If it's straight L5S1, I'm going to be lower. I'm going to be more transverse, right in line with the disc space. It's going to be lateral to the rectus muscle in this case. All right, and then in the lateral position, exposing the retroperitoneal space is usually quite easy. The abdominal contents are kind of falling out of the way for you. You get your finger in, you slide it up underneath the ilium, start your dissection, sweep your finger around over top of the psoas muscle, feel for the iliac artery, and then you know where your vein's going to be. You're going to go medial to that, obviously. So it's actually quite simple to expose these. There are a bunch of different retractor systems now that help facilitate this. There's retractors with lights that help facilitate visualization, so you can minimize the exposure that you do. The key is starting distally on the sacrum, sweeping up, looking for the iliac vein. That's the thing that's going to get you into trouble. That's the thing you want to mobilize and get out of the way, and protect with your lateral retractor. Usually exposing the opposite side is not typically an issue. The Camber is doing a great job of developing their variant retractor system, which helps facilitate these approaches very nicely. Okay, and just to finish up, this is a case. 31-year-old guy. He's got back pain. He's got right leg pain. He's got an L5S1 isthmic spondy. You can see the disc is narrow. His foramen's going to be narrowed. He's a big dude. He's 6'2". He's 283 pounds. Also by the way, got a history of multiple sclerosis, but he's quite miserable. This is his MRI scan. In addition to the foraminal narrowing, he's got a herniated disc on top of it. Rest of his discs look fine. I'm not worried that I'm missing any pathology anywhere else. He's too young to hopefully have bad facets. So I think everything's coming from L5S1 in this case. Again, I've evolved to the point where I'm doing these in a single position, using robotic assistance. I can plan my screws. Some of these cases of spondylolisthesis, the medialization of the L5 pedicle can be quite challenging. The angles that you need to get those screws in the right place can be quite extreme. So it helps to be able to plan where to put these things on a pre-op CT scan. Then we do Florida CT registration. So this guy, single position. I put blades in that were probably 200. I think they're the longest blades in the set. It was a long way to this guy's L5S1 disc. I didn't think I was going to get there, but got there. Did the discectomy, put in the Enza cage. I didn't really require much in the way of reduction, so I wasn't worried about that. I was more worried about his sacral slope and wanted to just to fix that cage in there in a way. And I think the Enza is a great implant for that if you don't need. But you see, actually, I did reduce them anyway just by distracting them, and they will reduce. But they're able to fix that cage in place and get plenty of bone graft in there. And then it was perk screws with the robot. So it's been over the course of my 25, 30 years of doing this, it's been a long journey, but I'm no longer a knuckle dragger, and I think this is the way things are going, and it's been very helpful. So just a little, we talk about this, and I've talked about this with the engineers at Canberra about, better implants and making things more stable. Is it feasible to do a standalone L5S1 spondylolisthesis? The short answer is I think it is, with a lot of exceptions. Okay, younger patients, not a steep sacral slope, small pelvic incidence. I think you can get away with it. They got to have good bone quality. You're not going to do this in your 65-year-old lady. It's not going to work. I think we need some better implants, but I think you can do it. But the literature basically says don't go there. High risk of failure. It's associated with the grade of spondylolisthesis, the degree of pelvic incidence, and sacral slope. So there's not really sufficient evidence in the literature right now to support that concept, but I think it's possible. Thank you.
So yeah, the L5S1. I'm glad the way Michael and others put together the program here, because I think L5S1 is very different than L4-5. And Jeff, I think your approach to L5S1, I agree with a lot of what you said. I look forward to some discussion about perking the back and outpatient surgery and things. But having said that, I'm going to talk about L4-5, and I almost think there's no area of medicine that's got more variation than what we do at L4-5. Whether we decompress alone, whether we dynamically stabilize, whether we fuse from the back, whether we fuse circumferentially, front and back. And that's why, in so many ways, I feel like this is a more interesting and more robust discussion than a lot of complex deformity things, right? In deformity surgery, it's like, are you going to do surgery or not? If you're going to do surgery, there's only one way to do it sometimes, whereas for degenerative spondylolisthesis, there's so many different things we can do. And in general, what I'm going to suggest here is that there's good evidence to suggest that fusion is better than decompression alone in certain cases. And if we're going to do a fusion, again, the durability of a circumferential fusion is better than a posterolateral only. And so that was a bit of an overview. This is basically a pathology we're talking about is a patient with a OLIF, intact posterior elements. So unlike what Jeff was talking about at L5S1, these patients have a ring that's intact and typically stenosis involving the traversing rather than the exiting nerve root. And here's a typical example, what you might see on an MRI scan, a patient with some foraminal stenosis, gapping in the facet joints. And again, the approach is characterized by a lot of variability. So in terms of our surgical options, decompression only, I think that this can be very useful, and I'll show you examples where I think that can be an appropriate approach, whether you do it at MIS or open. Posterior decompression with a fusion, and then the role of circumferential fusion, and again, going down towards motion-preserving options. So I often say that this variability is clear evidence of an absence of an evidence-based approach. So if we had clear evidence of what to do, well, we do the same thing every time. But a lot of times there's really clinical equipoise, and in this instance, I'm a real supporter of variation. A lot of times policymakers will talk about trying to develop a consensus, and clinical practice guidelines are an attempt to develop a consensus. But I actually think that we need to be responsive to many factors that don't really fit in. Patient preferences. I think surgeon preference also is relevant here. What might work well in your hands might not work as well as my hands. So I do like to put this discussion into some context and some history, and Harry Herkowitz, I had the chance to know well. We traveled together, spent time in Israel together, and you know, his original paper published back in 1991 at JBJS, he looked at his prospective series. This wasn't randomized, but he had 50 patients, half of whom had a decompression alone, half of whom had a fusion. Most of the fusions were actually done in situ, and he showed pretty clearly that the subset of patients who had a fusion did better than the subset of patients who were decompressed alone. Now, what's important to understand here is that, again, a lot of these fusions were done in situ, and he didn't really characterize how unstable these were, where the stenosis was. So it's a little hard to judge whether or not fusion truly is better than decompression alone, because we didn't have a great characterization of those cases. But this is what led us to believe that fundamentally fusion does better. In a subset of patients who had a solid fusion, meaning subsequently Kurtz actually showed the subset of patients that had a solid fusion did better than those who had a non-union, and that's what led to the advantage of instrumentation over the non-instrumented. But that was the background, and I think more recently, I'll just cite a couple of recent studies that I think probably most of you are familiar with, but just if you aren't, these were two studies that came out in the New England Journal in 2017, I think. One was from the Swedes, and you know, the Scandinavians do a terrific job. With a name like Sigurd, I could bash the Scandinavians a little bit. They do a really good job with their registries and do a really good job of following patients over time. A police state allows you to do that. I shouldn't say that, but that's not entirely true about the Scandinavians. I do think they gave up all their credibility when they gave it those horny little helmets. But anyway, this is a study that the Swedes did looking at a prospective randomized trial. So nice study design. These patients, a lot of them actually just had spinal stenosis. So it's important to understand that not all these patients had an olithesis. Only about half of them actually had an olithesis more than 3 millimeters. So they're randomized to decompression versus fusion. So why are we actually even thinking about fusing patients who have stenosis without instability? It brings up a question. And they looked at clinical outcomes. And what I want to point out here is they didn't show much of a difference. So the subset of patients who were fused obviously had more blood loss, more operative time, but otherwise clinical outcomes weren't that much different. They actually broke it down into a subset of patients who had an olithesis and who didn't, but suddenly now the population is much smaller. And again, they didn't show an advantage to fusion. In the same issue of the New England Journal, this is Zohair Gogawala. Zohair was a med school classmate of mine, and for those of you who know him, I think he's doing some terrific prospective multi-center research. And so he looked at laminectomy versus laminectomy with fusion in the SLIP study. So many of you are familiar with this again. Multi-center, randomized, we contributed some patients to this. And now importantly here, look at the inclusion criteria, because we're dealing with people with a relatively stable olithesis, okay? So if you had more than 3 millimeters of motion, then you weren't included here. And again, randomized to operative versus non-operative care. And in this case, actually, the group did show a slight, but in Zohair's words, a clinically significant difference in outcomes. And the biggest difference in outcomes was less revision surgery in a group of patients who were fused. And again, this was a subset, though, that were relatively stable olithesis cases. So again, small differences clinically, but significant, and less reoperation in a subset that were fused. So this gets to why I do what I do for degenerative olithesis. And to some extent, I think the appropriate surgery, as John said earlier, you've got to apply the right tools to the right patient. And I think I had a comic slide in there about applying the wrong tool to the wrong patient. I don't know why it got pulled out, because it wasn't that offensive. But it was... it was... it was somebody using a hammer to drive a screw in the screw bed. But anyway, so moving along with what are our specific goals, I think are important. So this is what I think about when I look at a case of degenerative olithesis. I think about the alignment. And I talked about that a little bit earlier, but you know, a lot of times these cases can be a little bit segmentally kyphonic. So I think about that segmental alignment. I think about the regional alignment. You know, I think about how much lordosis do I really need. I think that is important, even in single-level fusions. I really do. Where's the stenosis is awfully important, and I think it's very different when patients have got central or lateral recess stenosis that I can decompress. But when somebody's got a foraminal stenosis, I find that really difficult to get an adequate decompression when there's kind of a, you know, a pedicle on pedicle type of a stenosis. And I'm not very proud in telling you that I was part of the Baxano device, you might know, where we, you know, decompress the foramen. And you know, I'm not embarrassed, but I think that's something that actually works well in some instances. And so decompressing the foramen can be difficult, though, when there's that up-down stenosis. And then the stability of the spine. Again, we talked about this being part of the inclusion criteria of Gogolwala study. But, you know, if you've got 3 or more millimeters of olithesis or of movement on flexion extension, that might be a little different than somebody who doesn't move as much on flexion extension, or certainly than somebody who's got like bridging osteophytes. If somebody's got bridging osteophytes and doesn't move at all, even though they've got an olithesis, then, you know, maybe we don't need to necessarily fuse that. So to that end, with this is what I try and look at in every case. So with this as my framework, we developed and presented. We actually didn't publish this yet because we're still working on some validation work, but we presented this at NAS 2 years ago now, actually. And I looked at these 3 components: the structural stability, so the subset that really don't move on flexion extension, the subset that move moderately, and a subset that move a lot. And as you go down, you're more likely to fuse. So you're more likely to decompress somebody who doesn't move much and fuse somebody who moves a lot. Similarly with the pattern of stenosis, if it's kind of central stenosis or lateral recess only, I'm likely to decompress that. Whereas if it's more of a foraminal stenosis, I could still probably take out some of that SAP with the decompression only, but it's harder. If you have real up-down stenosis, you know, completely collapsed disc, pedicle on pedicle, that's something I'm almost certainly going to put an interbody in and get that foraminal indirect opening or direct opening. And then, you know, again, alignment, I think, is something we need to pay attention to. So somebody who's kind of segmentally lordotic, I don't need to realign, as opposed to somebody who's really kyphotic, and I showed you a case of that earlier, right? Somebody who's kyphotic at 4-5 and fused into kyphosis. That leads to adjacent segment problems. So these are kind of 3 things that I look at, and I think about the subset of people who are at top, you know, lordotic with lateral recess central stenosis, don't translate much, I decompress, and people who are at the bottom, I'm more likely to do a more complex reconstruction on. And again, the foraminal volume is a big part of this. When I look at patients with foraminal stenosis, I'm much more likely to try and open up that foramen by getting something in the inner body space, and just those pictures from Rauschning. So that's the way I think about degenerative spondylolisthesis, and I guess I still took almost 15 minutes, so I thought it was going to be shorter. But just to show you as an example, this is the case I started with. I showed you the MRI scan earlier, had foraminal narrowing. In this case, actually a pretty big, well-maintained disc height. But just typically what I'll do is a TLIF, and that's a typical example of what I'll do. So overall, I think circumferential fusions have better durability, less revision surgery, and are cost-effective compared to posterolateral fusions only. And I think the fusion rates are better. We get a better foraminal decompression by having something in interbody space. We can create some segmental lordosis and get some deformity correction. And that's my typical approach to a degenerative spondylolisthesis. So, thanks.